There probably should be a word missing from here, which is either some doctors or probably other, depending on your level of delusion about whether you think you can recognize dying or not. I want to start with a joke because it's always a good place to begin. And also it tells us as much about our colleagues and the way we perceive them as it does about how they perceive us. I've never been to an oncology conference. I should imagine they have jokes about why no intensivists ever admit their patients. But I think it's also important to use humor and black humor in some ways to work out why we behave the way we do and the way we, in many ways, delude ourselves about what it is that we're doing and why we're doing it. This is a sculpture outside a hospital in the US, and if there was a single slide I wanted to use to sum up what I'm going to talk about, it would be this picture, in which the physician or nurse is depicted as this muscle-bound heroic figure fighting off death at all costs. Now, if you're a patient, you'd want to go to this hospital because you'd think, this is awesome. They're heroes, they're fighting for me, death will be dispelled. But what that means probably is that you're going to die at all costs, and that the quality of your death, if you're dying, is probably not going to be very good, because there's a focus on essentially preventing death and not providing you necessarily with a good death. And the bad death we've all seen, some of us maybe more recently than others, and we can describe it relatively well, and it follows a relatively predictable theme. It often occurs in an acute hospital bed. Certainly if it's out of hours, the family may not be there. There will be a worried-looking member of a medical team or a nursing team standing next to the patient. Sometimes it occurs immediately after a treatment or procedure or soon after that wouldn't have altered the outcome of what's actually happened, possibly even as a complication of a treatment or procedure on something that was done despite the fact that someone was dying. The patient themselves may be unaware that they were dying or that this treatment or procedure was being done to them to try and stop them dying, but was likely to be futile. There's often a lot of monitors and alarms flashing. From the patient's perspective, often the curtains are pulled back and the patients in surrounding bed spaces can see as they go. And often there's an ignorance of their cultural spiritual needs. And my argument is that in many acute hospitals, this is often the default way by which we and our patients are condemned to die. And the reason I'm going to talk about that essentially is threefold. I'm going to blame all of these three factors that contribute towards why we as doctors are in denial about why our patients are going to die. And I think doctors are obviously members of the society that we live in, and there's a societal component around death denial that's been written about extensively. Patients often can enter this folie à deux, this madness of two with their doctors that they're not going to die and their doctors don't believe they're going to die, and often they're self-reinforcing. But also I want to put some of the burden on training of medical students and training of doctors in postgraduate schemes about the things we focus on and, more importantly, the things we don't focus on. I always use this slide whenever I talk about death because it's inevitable. All of you are going to die. I am going to die, hopefully not today. But ever since mankind has evolved, humankind, womankind has evolved, we have 100% mortality. No one has ever lived forever, and your patients are going to die. And if you think that's not the case, then you're deluding yourself and you're deluding your patients as well. Now, we're fairly late to this from a medical perspective. The Catholic Church started this about 700 years ago with their treatise called the Ars Moriendi, which is literally called the art of dying, which put the patient at the center of their own death. When you were thought to be approaching the end of your life, often in your 30s or 40s, your family would gather around you in your deathbed, and the patient was in charge of what happened. When they felt they'd said their goodbyes, they would summon a priest, and the priest would come along. And this is a very Western-centered worldview, but this is essentially how most Western hospitals now deal with death, based on what happened back then. The patient was allowed to determine when they were dying, and they said goodbye to their family. The priest was called, and the patient was at peace. What's happened over the next 300, 400, 500 years is that death has been removed from the home and been removed from the family. And with the rise of the medical industrial complex, death now largely happens in hospitals. The patient has little control over the process. And not only that, certainly in the Victorian era in England at least, that the focus moved away from the person who was dying and onto the mourners themselves with these elaborate rituals. And the person who was dying became largely irrelevant. The focus was actually now on the family and their grieving process. So things have changed, and many people have actually probably never even seen a dead body. Certainly before I went to medical school, I can't remember seeing anyone die, and I never had seen a dead body either. So when you come to society and the way you examine why patients have these perceptions, this is a great series of papers that basically involves sitting in a room and watching lots of television shows to see how people were informed about the way people die in the media. And there are two countries represented, but a variety of shows. That's a heck of a lot of episodes, each one coming in at somewhere between 30 and 45 minutes. And if you look at the number of arrests, firstly, it appeared that there was a significant number of cardiac arrests, but their survival and their return to spontaneous circulation is deeply incorrect. Most people will get up and walk away, and we know that that's not the case, particularly as a result of these injuries. Many of them were traumatic, and we all know that traumatic cardiac arrest has a much worse outcome than arrests by other means. So the societal perception is if your heart stops and you get CPR, you're probably going to be okay. They also, as you can see, over almost half the patients were less than 35 years old, which we also know is deeply unrepresentative of the demographic of people who actually have in-hospital cardiac arrests. So this folie à deux I mentioned earlier comes from a variety of things. This is a paper from JAMA, who talks about the guilt of patients and their families they may feel because their physician is investing so much time and energy in them that if they don't get better, they feel partly responsible, which seems ludicrous, but I can see how you'd end up in that situation. When doctors offer tests, the family may feel part of what they want to do just to make sure, because if they don't get the test done and they die, then what happened in hindsight if they had have got the test done? So you have this self-propelling mechanism where more and more stuff gets done, even on people as they're dying. So you may think I'm being overtly fatalistic. So how do we know that all these people are going to die? Well, here's a great paper from Scotland, and it might say something about the health of the Scottish. But it looked at 10,743 inpatients in Scottish hospitals, 25 hospitals in the NHS Scotland, and it followed them up for over a year. 29% of patients were dead within 1 year. Now, for those of you familiar with the palliative care surprise question, would I be surprised if this patient was going to be dead in a year? If you tossed a coin, you'd have a 50-50 chance, but the chances are a third of your patients will be dead within a year. I wonder how many of these patients actually knew that was going to be the case. I would argue probably not that many. The paper that Forbes alluded to earlier, the Economist survey, looked at what people actually wanted across 4 countries. And what's interesting, excuse me, is that the least ranked comment was that for most people, living as long as possible was the least important thing. You can see a difference there between socialized healthcare systems and systems where you have to pay for your own care. And certainly in Japan and the US, the biggest thing was they didn't want their family burdened financially. But what people actually seem to want is not to live as long as possible. Yet, most medicine, I will argue in a minute, trains you that that's actually what they want you to do. When they also asked people if you had a choice, where would you prefer to die versus where you think you're actually going to die, there's this incredible but probably predictable disparity, with people in the majority wanting to die at home and most people fearing that's probably not where they're going to die. And if you look at where people actually die, you can see that there's a significant variation. Interestingly, where I work in New Zealand at the bottom, it appears to have the lowest rate. A third of people die in hospital. In Japan, it's double that. So there's this big disparity between where people say they want to die, where they think they'll die, and where they actually die that's different across the entire country, across the entire world, rather. So when you're a doctor and you meet a patient for the first time, and this can be either as an intensivist attending a MET call, it can be a patient in the emergency department, it can be someone you meet on your ward round, they all look the same. And it's really difficult to know, in going forwards, what best use of resources you can provide. Because if that patient is actively dying with a process that is irreversible, then how many resources are you going to allocate to them? Are you even going to mention to the patient that you think they might be dying? And because when you meet many people for the first time, this differentiation is quite difficult, because death is, or dying rather, is often something that's determined in hindsight as opposed to going forwards. You can see why there's confusion about why doctors often don't recognize dying. So this is how I reckon most medicine works. This is a completely disorganized flow diagram. And I'm going to talk a bit about, I guess, how we ended up in this situation. So imagine you're a physician. You meet a patient, you admit them. I suggest the first thing you should ask, based on that Scottish data, if your 30% chance of being right in a year is, are they actually dying? If you're not sure, think about it again. Ask yourself the question, are they actually dying? And if you're still sure they're not, then do some medical stuff, because that's what we're trained to do. Medical stuff's awesome. It distracts you. It gives you pause to thought. It moves you away from actually having to talk to the patient about bad things. And then ask yourself, did you actually make them better? So you've done a whole load of medical stuff. If you've made them better, that's fantastic. You've got something you wanted. You're the hero on the wall of the hospital fighting death. The patient's happy. They get to go home alive and go back to their family. If you didn't make them better, then maybe you should think, actually, I've done a whole load of stuff and they're not better, but they should be. Are they actually dying? At this point, you should probably tell them that there's some uncertainty now. I'm not sure that the stuff I've done is helping you. What would you like me to do? And very few people, I would argue, ever have that conversation. So if there's uncertainty, then put that to the patient. What would you like us to do? We can keep doing stuff. We can send you for operations, CTs, MRIs, PET scans. Or if there's uncertainty and we think you're not going to survive, then maybe there are other things you'd like to do, like maybe meet your grandchildren before you die inside a CT scanner. So the reason there's a problem is this, is that what medical school teaches you is the stuff in the green box. It teaches you to do medical stuff. Now, I've not been a medical student for a while, but I'm involved in training medical students, and I ask them what their medical school teaches them. And what medical school teaches them is the old paradigm that medicine has been founded on for millennia, which is to diagnose disease, to treat it, and to cure people using whatever means possible. It also teaches doctors to make decisions. So based on the evidence that you have, to make a decision that hopefully will help your patient. Now, we like measuring stuff. And generally speaking, if you can't measure, then making decisions makes things a lot harder. I wrote this slide slightly flippantly and thought, I'll just Google death biomarker. And sure enough, there's a whole series of papers that people have written trying to imply there are, in fact, now biomarkers for death. That you can measure troponin, you can measure your precepsin, but now you may also soon be able to measure a random chemical that may or may not be associated with you dying. So this slide historically may now actually not be correct. Richard Smith is an ex-editor of the BMJ, and he's spoken a lot about these things. And this is a quote from him. He's commented repeatedly on the fact that patients are getting more and more complex with more and more disorders, and doctors are getting more and more specialized, focusing on more and more single organs, and that patients and doctors essentially are moving in opposite directions. Now, the reason this is happening is the rise of what I call the SODs, the single organ doctors, and the fall of the multi-organ doctors. The multi-organ doctors are getting less and less and less, and the more close you are to a tertiary teaching hospital, the more likely you are to be looked after by a single organ doctor who knows an incredible amount about that single organ. I used to work in a very large center where there was a right heart cardiologist and a left heart cardiologist. I cannot think of a single drug that works on the right heart that doesn't work on the left heart. And sure enough, the right heart cardiologist would round with their team when they'd make some changes, and then the left heart cardiologist would round with their team when they'd come along, and they'd have an argument about which side of the heart was the most important. And in the middle of this is a patient thinking, what the hell is going on? Why have you artificially divided up my organs when I'm made of lots of them, and because I'm now 70, 6 of them don't work? So we've conveniently divided up patients because we want certainty, and single organ doctors become single organ doctors because they want certainty in what they're doing. Whereas multi-organ doctors, which conveniently patients require more of because they have multiple organs, are often left there with conflicting opinions trying to work out what the single organ doctors want. There was an interesting quote I read recently that suggested that the role of the generalist is to protect the patient from the specialist. And I think probably increasingly that's true. Richard Smith again talks about the old medical model that we teach. We teach medical students that patients come in with single acute pathologies, that they have short-term conditions that predominate in their lives, that our entire focus is to diagnose, treat, and cure these people, and that the survival of the patient is dependent upon the skills of the doctors and the nurses looking after them. What he suggests is that actually this isn't true. What patients have is multiple chronic problems. They have long-term problems that we're ill-advised and society is ill-advised to look after. But also, the main role of a physician now is to ameliorate, listen, explain, advise, and dare I say, console, to say that must be awful for you, but there's not very much I can do. And the biggest point he makes is that your survival advantage now is not dependent upon your physician. It's actually dependent on the lifestyle choices that the patient makes. Because you have a chronic disease, how well you manage your diabetes, how high your HbA1c is, how much you exercise, and how much you smoke. These are the things that will determine your long-term survival, and not actually the skills of the doctors and nurses who look after you. But patients are often unaware of this. I can't get through this without mentioning surgeons because I'm in awe of surgeons. I work with them regularly. I work in a mixed cardiothoracic neurosurgical medical ICU. And I had previously little concept as to how involved they feel in the care of their patients. So I tried to explain it in a way I could relate to as an intensivist. And the best I could come up with would be to imagine if every patient I put a central line in, 10% of them developed a pneumothorax, and of those 10%, 1% of them went on to die from a tension that I couldn't treat. Now, as an intensivist, that would be pretty sober. First thing you'd stop doing would be to put central lines in people, and secondly, you'd be very upset if anyone started to get ill afterwards. But the surgical mindset of actually actively doing harm to someone in an effort to try and make them better is something that I think as intensivists we're not very good at. And when you're in a meeting with a surgeon and a family member and you're trying to say, I think there's nothing else we can do and the patient's dying, and the surgeon's actively resisting that, part of that is because the psychology involved in actually doing their job physically involves doing harm to someone to make them better. And I think we as intensivists have little insight into their world. And increasingly, the more surgeons and the more senior surgeons I work with, the more respect I have for their worldview. And realize that actually it's really difficult, that when we want to talk to patients in ICU about dying, the surgeon is saying, oh, but there must be something else we can try, because they're much more personally involved with the harm that patient suffered than we would ever be. So, I've talked about the fact we're all going to die. Now I'm going to tell you how you're going to die. Essentially, there are 4 ways. The first way is, ironically, the way most people would prefer, but the way probably their family wouldn't prefer, which is suddenly you die, your car explodes into flames, and you had no concept that it was coming. You have no chance to say goodbye. Your family get that awful phone call from, God forbid, an intensivist or a policeman saying, I'm afraid that your loved one is dead. Now, this is a small minority of people, predominantly in New Zealand. It's revolved around generally men between the age of 16 and 20 who are high on some form of drug driving a car at speed into a tree. The next one is slightly more insidious, and it gives you more chance to say goodbye because you can see it coming. This, generally speaking, is for cancer. So you have a high level of function, you develop a cancer that is either poorly responsive or not ameliorated by treatment, and you continue to decline and then you die. The third way is probably the one that I would argue occupies most acute beds in most hospitals, which is a disease process probably typified by something like, say, chronic heart failure or chronic lung disease, where you have a period of time where you get worse acutely, but then you're treated and you get better. But the underlying progress of the disease is continuing unabated and will end in your death. But what happens is these intervals get closer and closer together, and when you recover from your interval, you never get back to where you were the day before you got sick. So it's essentially accumulation of small deaths that ends ultimately in your final death. And then there's the what's called dwindling phase, which essentially is linked with a lot of things, including dementia, senility, and people who essentially are just slowly dwindling towards their death over a period of time with a gradual loss of function for which no acute doctor is ever going to actually make a difference to that. And you may think I've made these up, but here's a great paper that's from the UK looking at GPs, in which they analysed a whole series of deaths in their practice and looked at actually what happened to these people. And they went back retrospectively looking at people who died, and they talked about this uncertain dying process and go all the way back to 30 days before their death. The end point of which ends up with the patient in a hospital, which wasn't where they wanted to be because they'd started out in a nursing home where they'd rather have died. And you can look back, because this is in hindsight, and look at any one point thinking, well, actually, this probably isn't going to go very well next. So when you meet a patient for the first time, the whole point of what medicine is for is to do this. Something happens, something bad happens, and you have a medical intervention, and that patient gets better. That's what we're trained to do. That's what our healthcare system is funded to do. This is why we all became doctors, nurses, etc. In reality, in many cases, what happens is we have no idea where that person is. And what we do in hospitals, essentially, is this. You have someone who's deteriorating, and you meet them towards the end, and what you've done essentially is delay their death by a number of hours, days, maybe even weeks. But what you've not done is actually change their trajectory and got them back to a level of function that they want to be. And there's a variety of reasons. I think this is probably illustrative as to how we teach doctors and how we teach nurses. And it comes down to the simple way, in fact, that out-of-hospital cardiac arrest is taught not just from a management perspective, but if it's exactly the same thing as an in-hospital cardiac arrest. And a speaker yesterday alluded to the fact that despite improvements in out-of-hospital cardiac arrests, the mortality for in-hospital cardiac arrest remains double that. So to put that in context, if you're outside in a shopping mall and you drop dead, you're twice as likely to survive than if you're in a hospital bed and you drop dead. Now, that either says that it's a pretty damning indictment of the hospital system or how awesome the pre-hospital systems are. But in reality, what it is if you drop dead in a hospital bed, it's because you were dying, because you have complex multi-organ disease for which the treatment is not CPR. CPR should only ever be used for when the heart is the first thing to stop, not the last thing to stop. But we teach everyone to provide it by default for people because that's what doctors do. We do CPR when your heart stops. And Forbes' data has shown the incredible variance across the world with regard to who should be receiving who CPR and who shouldn't. I stole this from someone because I think it's a great Venn diagram. The question I often get asked is, what the hell has this got to do with you? You're an intensive care doctor. You've got nothing to do with palliative care. And essentially, I'm giving a palliative care talk. The answer is that we get invited to the bedside of dying people way more often than palliative care doctors do, because we invented all these systems. We invented MET teams, we invented early warning scores. We invented means by which doctors have to call us when their patients are sick and dying. The problem with palliative care is that you have to have the insight to know that your patient is dying before they actually ring you. Whereas we have a very rare advantage of being by the bedside to allow us to say, to almost give permission for someone to die and say, look, it's okay, this patient's probably dying. I'm afraid there's nothing we can do. The phrase I've used before is palliative care physicians are like vampires. You have to invite them in. You can't do anything unless you invite them across your threshold. So my final slide, how can we change things? Having filled you with doom and gloom and the fear of your impending demise, I think what we should do is encourage palliative care training. We should encourage certainly intensive care trainees, and the few of our trainees who've done it have said it's taught them way more things possibly than anesthesia, possibly than acute medicine ever did, not least of which is the ability to communicate with patients and their families. We should talk to our patients about dying when there's uncertainty, because patients, it would seem, want to know if we don't know what we're doing and we're uncertain about what's going to happen. Because our uncertainty shouldn't turn into their inability to have conversations with their family about bad things. We should invite palliative care physicians to attend our multidisciplinary meetings. We regularly have rounds with palliative care physicians in our ICU reviewing patients, just in case we've missed anyone who's dying. And they sometimes ask the questions, are you sure you should be doing this? Which has caused us to reconsider. I think as probably general organ physicians, we should protect our patients from single organ doctors, but we should always consider, is this patient actually dying? Thank you very much for your time.